Now coming on to our last topic, that is the leg length equalization. In this, we will be discussing what are the different options available for leg length equalization. Usually the children can have a massive leg length discrepancy, be as high as 10 to 15 centimeters. So we will be briefly discussing what are the operations in the longer leg, what are the surgeries which can be done in the shorter leg, and what are the options to increase the stature of the person. So if you see this diagram, now if this child has around this much 2 to 3 centimeter or 4 centimeter of shortening, which can be actually calculated by using a block. A certain block is actually placed until both the knees and hips are at the same level. But what could be the problems for this patient? If the patient in a normal walking gait would have increased stress over, as the right leg is shorter, there will be increased stress on the right hip. Therefore, the knee or left knee will have to be bent slightly so that the patient can keep the pelvis at the same level. So this would result in actually a problem with the right hip, leading to right hip arthritis, actually early changes in there, and plus left knee contracture as well. Therefore, this is what actually happens is if there's a limb length discrepancy in a child, this can be massively problematic, not only in terms of that the patient is unable to walk properly, because usually the secondary changes which eventually leads to arthritis in the hip can be very damaging, and they may require early hip replacement in these patients. So actually that is important, that why this inequalities occur. This could be multiple causes. There could be congenital causes. For example, it could be due to congenital talipes equinovarus, it could be DDH, it could be multiple, for example, other causes such as proximal femoral focal deficiency. These are the congenital causes which predispose a child to limb length discrepancy. Or there could be neuromuscular diseases such as cerebral palsy, polymyelitis, in which there is a spastic paralysis of the muscle which is predisposing the patient to LLD or limb length discrepancy. Or there could be other causes as well. For example, the patient has some kind of a trauma eventually leading to physeal arrest, and therefore one leg is actually growing normally. The other leg, due to physeal trauma, has actually stopped growing, therefore eventually leading to limb length discrepancy. So we have to, important is that longer leg has to be lifted higher, and the problem would be the other eye has to, he or she has to bend the knee of the longer leg so that he or she can stand properly. Therefore, the problem is the pelvic tilt, as I just told you. Therefore, if this is the case, child has a right short leg, there will be increased chances of right hip arthritis. There could be associated compensatory scoliosis, which would eventually lead to increased back pain and all those symptoms. And there could be other causes as well. Or there could be osteoarthritis of the hip joint. There could be inequality which could be greater than 2 centimeter, may need some kind of a treatment. Usually in a human person, 1 to 2 centimeter of limb length can be tolerated. That is why we can use a shoe lift or shoe raise. Therefore, this amount of degree can be easily tolerated, but anything above 2.5, something has to be done regarding that amount of limb length discrepancy. Other techniques which can be actually, the important point is, first of all, we have to take the history examination of the patient and do certain pre-operative tests. For example, x-rays such as CT scanograms may also be required, or there could be röntgogram, that is a whole full length x-ray from the hip till toes as well, may also be required. Once we have all the x-rays, we know whether the problem is at the tibia, problem is at the femur, or it's just at the knee, that is the distal femur and the proximal tibia. And once we know that, we know where the problem is and how much limb length differences there actually. It could be easily divided into 3 types, that is less than 2, 2 to 5, and greater than 5 centimeter of difference. If the problem is actually less than 2, then we probably easily can be treated without surgery in form of use of shoe raise only. And shoe raise can be given on the shorter foot or shorter side, and the patient can have a normal LLD. But if the problem is around 2 to 5 centimeter, therefore we may have to go for the shortening of the longer leg, that is the normal leg. Although it's a good possibility, but this is where you have to sometimes decide that if we imagine that photograph we just showed in the previous slide, the right leg was short and the left was long. If we are going for a surgery on the left leg, which is actually normal, there is always a chance that that can have a problems later on as well. So if his or her one leg was already problematic, you have given him another problem leg as well. So that is why sometimes it's tricky to actually go for the shortening of the longer leg. But usually with 2 to 5 centimeters, we have to go for procedures which actually shorten the longer leg, which could be in form of osteotomy, or it could be in form of epiphysiodesis. Other process could be actually the slowing the growth of the longer leg, that is in form of epiphysiodesis, in which the growth is actually retarded, so that eventually at adult stage, that is at 14 years for females and 16 years for males, there is minimal amount of leg length discrepancy which can be later on corrected. Then if it is more than 5 centimeters, then usually instead of shortening the normal leg, because more than 5 centimeter shortening would produce a lot of problems for the patient, will not be able to have a normal musculature, which is actually more than 5 centimeter shortening cannot be done. Therefore, we have to go for the procedure such as lengthening of the shorter leg, which can be actually combined with either slowing the growth of the longer leg or shortening some degrees, short around 2 to 3 centimeter shortening of the longer leg along with the lengthening of the shorter leg, so that if suppose it's 10 centimeter of LLD, then we have to combine certain procedure times as well. Then fourth option is actually speeding up growth of the shorter leg or actually combining the different procedures. How do we actually calculate limb length discrepancy? There are multiple methods by which the limb length discrepancy can be calculated. Actually, different methods include Moseley charts. There is green Anderson charts as well, which actually depict how much limb length discrepancy would be present. If the child has, suppose 2 centimeter of LLD at 8 years, how much this would have at 14 or 16 years of age. That is, the other option is actually Tanner staging, which has been used actually nowadays. That is, Tanner Whitehouse method is they take the radiograph of the hands and they calculate the radiological and chronological bone age. By calculating that, they actually calculate how much limb length discrepancy and bone growth will occur and how much limb length discrepancy would be present at adult age. That is also one of the methods, but the other method is very simple. That one is called as simply estimation methods. That if the problem is at the proximal physis, that means almost on average in a year, 5 mm of growth takes place at the proximal femoral physis, and around 9 to 10 mm of growth takes place at distal femoral physis, and around 6 mm of growth takes place at proximal tibial physis, and around 5 mm of growth takes place at distal tibial physis. So if a child had an injury of knee and his physis was damaged due to traumatic injury, then let's suppose he or she had actually problem with the left knee, and she is actually 8 years of age. And now if the limb length discrepancy is 2 centimeter, we know that 9 or 10 mm of lengthening is done at this, or growth actually occurs at distal femur, and around 6 mm at proximal tibia. So that would mean actually almost 16 mm of growth is occurring at this area. If that is damaged and the child is female child is actually 80 years, then that means she is going to grow till 14. So she has still 6 years of growth present. If you multiply this 6 by 16 mm and you add 2 centimeter of current, you actually get the actual amount of limb length discrepancy which would be present when she will be at 14 years of age. That is how a crude method of estimation actually can be utilized to exactly diagnose how much limb length discrepancy would be present of a female child at 14 years and of a male child at 16 years of age. Now, what are the different options available for the longer leg? These could be simply a physeal arrest, which could be temporary or permanent. What we do is we actually use simple drill bits to destroy the physis, and which could be permanent as well, and then stapling it. Or the other option is actually stapling it only for temporarily without damaging it, and once the staples are removed, the physis can grow back normally. Usually excision of rectangular block is actually done, but that is only if this physeal bar is actually a problem and there are only less than 2 years of growth remaining. That is, for example, a female child comes to you at the age of 12, or a boy who comes at the age of 14, he or she has actually less than 2 years of growth remaining, then this physeal bar can be simply resected, or this could be rotated through the 90 degrees and put back in so that it does not actually affect the growth much. That is only when less than 2 years of growth is remaining. Other option is epiphysiodesis, that is by use of permanent epiphysiodesis can be done by drilling, or temporary can be done by use of staples. Other options could be the longitudinal growth, that actually that side has to be decreased so that the increased limb length discrepancy which would be present must be reduced as much as possible. Other options include is the physeal arrest. For example, timing and technique of epiphysiodesis is important. And if we are dealing with the problems at the knee joint, we have to be sure that at knee joint this maximum growth of the lower limb is actually taking place. So that also needs to be remembered, that how much growth is remaining, how many years of growth is remaining, and how much which area is affected most. For example, epiphysiodesis of the usually contralateral side is actually done so to retard the maximum amount of LLD which can be present later on in life. Other option, as I just told you, is inaccurately timed limb length discrepancy usually results in there is some degree of LLD even at the adulthood. But then depending upon, sometimes if we just call it damage control, that you're expecting a 10 centimeter or 15 centimeter of LLD. You do the epiphysiodesis of the longer side, you make it sure that eventually the LLD remains around 4 to 5 centimeter. Then what we can do is we can lengthen the shorter side as well and eventually make up for that. So sometimes, depending upon the situation, depending on the patient and age of the remaining growth, that we have to make a logical decision. Leg length loss could be done by, as I just told you, that usually loss of 10 mm of length a year from distal femur. If epiphysiodesis of distal femur is done, 10 mm per year is actually of lengthening is actually decreased. And if it is combined with proximal tibia, then it becomes 16 mm. Or if only the proximal tibial epiphysiodesis is done, then that actually gives us 6 mm per year of proximal tibial growth can be arrested by use of epiphysiodesis. Other options of bone shortening. Now this is actually a diagram which uses an osteotomy. If you see, this is the femur. Osteotomy was done, nail is being placed, and this area is actually used as stratigraph, and overall the bone is shortened. Osteotomies usually with the femur is easy, and that is has good results as well. Usually using an osteotomy to decrease the length of the femur of the tibia usually has not been very successful, and it's not very much advocated. Usually if you have to perform some kind of epiphysiodesis, after epiphysiodesis still we may have to go for some kind of shortening. We usually go for the femur. As I just told you, usually the excised segment is between the lesser trach and the femoral isthmus, and approximation of the cut end is done, and that can be used as a strut graft and eventually fixation with the locking intermediary nail so that the length is shortened. Other option is actually the bone shortening is actually open excision scarring of the poor muscle tone. Why? Because if too much bone is actually shortened, this would eventually result in imbalance between the muscles and improper tone of the muscles. Then short segments intermediary method can also be done as well. Or when used, the patient may be too old for the epiphysiodesis. For example, if a child comes to you in adulthood when the fascia are already closed and we cannot actually retard the growth now by use of epiphysiodesis, therefore we may have to go for some other procedures such as osteotomy of the longer leg or lengthening of the shorter leg. That is how we make the difference. Now coming to the lengthening of the shorter leg. As I told you, if the limb length discrepancy is greater than 5 centimeter, then shortening of the long leg would not be a good option because this would produce the improper muscle balance. Therefore, we will have to increase the shorter leg. Now, increasing the shorter leg could be through multiple methods. This includes simply using a shoe raise. That is, if it is less than 2 centimeters, just give an extra padding in the shoe so that it actually raises the shoe and pelvic height is restored. Other could be periosteal division and growth spurt stimulation, although this is not very much successful. but usually 5 mm strips can be excised from distal femur or proximal tibial physis, where the maximum growth is actually taking place. But the important point is, if we are dealing with the physis and we are with this kind of manipulation of the physis, usually this has some degree of damage to the physis as well, which eventually may produce angulation, which has to be remembered that we to be very precise when we are dealing with the physis. Therefore, when we are trying to increase the growth, we may also increase an angular growth as well. Therefore, the best method usually is a laser-off lengthening, that is a circular frame being utilized across the femur and the tibia, and actually the both bones can be extended at the same time. Important point is actually it is that usually maximum amount of 1 centimeter growth, 1 mm per day can be 1 centimeter, I just said it could be at least 1 mm per day. Lengthening can be done by use of a laser-off. Other options could be use of osteotomies and then use of graft, so that the shorter length can be increased. Our staging treatment, that one surgery we increase the length of the femur, in the next surgery we increase the length of the tibia. Therefore, overall the limb length discrepancy can be decreased. Simply, use of bifocal lengthening could be done by the use of a laser-off, in which both the bones are increased continuously. Now coming to the operations which can be used to increase stature. Technically, yes, bones can be lengthened, but although practically it's not very feasible option because it's cumbersome, it takes a lot of time, and it can be very damaging as well. Usually bilateral leg lengthening is required. It could be painful and prolonged treatment, which is usually the problem with this, associated with complication, because mostly the limb length discrepancy done by use of either laser-off and circular frames. Therefore, pins going into the bone, they can be infected, and there will be pin site sepsis and deformity, or pin breakage and complications like that. Moreover, there could be two bones although can be dealt simultaneously, both tibia and both fibulas, but the problem is that usually there is a differential between the growth. Sometimes the tibia is growing on the proximal side is growing more than on the distal side, and this eventually produces some kind of angular deformity as well. So although theoretically increase in the stature possible, but practically there are different other options which are usually not taken because of so much it's a cumbersome time taking process associated with a lot of complications. Now one has to remember that it's almost 20-25% centimeter of the bone can be lengthened. That is, if the limb length discrepancy is around 20 plus centimeter, then usually it's not very easy that despite the shortening the long bone, despite lengthening the shorter bone, we may still not have the ability to achieve a complete limb length equality. Therefore, in that case, usually the best option is to amputate the limb and give the child or a patient a good fitting prosthesis so he or she is able to walk properly. That is what is important, because we need to have remember there's an upper limit of more than anything above 20 is highly impossible to equalize that kind of a limb. So usually 20-25 centimeter above, the first step is to go for amputation and give patient a good fitting prosthesis. In this section, we have briefly gone how to equalate the limb length discrepancy. As you know, this could be multiple causes, could be congenital, could be paralytic, neuromuscular, traumatic causes. Most common, the most important, most of the growth which occurs around is at the knee joint. That is about 10 mm in the distal femoral physis, 6 mm in the proximal tibial physis. Therefore, the injuries to the knee could be highly damaging and lead to limb length inequality. Therefore, to equalize limb, we have multiple options. If it is less than 2 centimeter, we can simply give the shoe raise to the shorter leg so that the limb length is equalized. If it is 2 to 5 centimeter, we can go for either the contralateral epiphysiodesis, that is the longer leg can be epiphysiodesed or halted, and or we can go for the shortening of the longer leg. And if it is more than 5 centimeter, we'll eventually have to go for the lengthening of the shorter leg with use of laser-off frames or multiple osteotomies, or maybe with the use of stage procedures. Thank you very much. Keep watching sqadia.com.